Hi, my name is Dr. Gallo Grijalva. Today I'm going to give you a presentation on weight loss or bariatric surgery. We're having a short introduction. We're actually going to define what obesity is. Most people think that they know what it is, but we're actually going to give a good definition of it. We're going to talk about the causes of it. We're going to talk about the current trends, what's going on in obesity today. We're going to talk about what it does to our health. We're going to talk about the medical and surgical treatment options, and then we're going to have a small part about our practice, some pictures, and I'll have a link to a video where a lot of what I said can be seen in a more succinct and short way. So, first off, what is obesity? Most people think that the word fat should be somewhere in there, and what we know about and what is actually the new definition is that this is a chronic life-threatening disease. Obesity is excessive body fat that leads to serious health problems. It is an independent risk factor for a large number of those problems, and it can lead to significant medical, physical, psychosocial, and economic problems. So, one of the biggest questions is, why me? What causes obesity? And we know that obesity is a multifactorial disease. It's somewhat fairly split between our genetics and our current environment. So clearly we understand and know that there's a genetic predisposition for this. This can easily be seen by looking at twins, looking at families, looking at adopted kids. We know that it's not just a single gene, but probably multiple genes that create this environment. So our genetics tells our body how to function. So people that are predisposed or have this disease may be better energy storers. Their stomachs may stretch differently. They may have different hormone receptors or affinity for those receptors. Certainly this is an evolutionary ongoing issue. Other issues that come into being are behavior. What has food been done or taught to as a person? And that can start as early as the type of breast milk or not breast milk that is being given. Is food a comfort? Is it a punishment? Is it an addiction? We know that women naturally have a slightly higher percentage of body fat. We know that this disease doesn't discriminate based on income. Whether you have a lot of money or not, people still get this disease. Now, there is a subset that people with poor income have access to more calorie-dense and poor food. Now, psychosocial. This could be a coping mechanism due to stress or abuse that may be because of the obesity, especially in our society today, which leads me to where we're at, and that's the opposite of our genetics. So today in our society, we have technological advances that have made it so that we don't have to expend a lot of energy. Also, the environment has led to a place where food is widely available. So we end up in this very difficult to get out of weight gain cycle that is primarily comprised of our genetic and environmental problems. So with those combined, we end up storing a large amount of energy, which leads to metabolic, hormonal, anatomical, and physical changes. These changes bring on these comorbid diseases with obesity. Clearly, when people are sick, they're distressed. And of course, you still have to eat. So this becomes a very difficult cycle to get out of. So the basic problem for obesity is that we have an energy imbalance. At its most basic, we are a modern society, humans with Stone Age genetics. So today, there is plenty of food in most developed countries where this is a problem. The food is easy, cheap, addictive, energy dense, and because of our technology growth, we don't have to do anything to get that food. We don't have to expend any energy. The net result is that we continue to take an increased amount of energy or calories, and we're not expending that energy or calories. And so that weight gets stored. Now, we measure obesity by a ratio of weight and height, and it's called a body mass index. This is a simple formula that can be placed into any phone, put in BMI calculator, put in your height, weight, and it will spit out a number of BMI. Now, there is a range of BMIs. If I did not have this nomenclature above here, and I showed most people that silhouette and asked, does that look like a normal or a skinny person? Most people today would see that as a skinny person. Unfortunately, that is the normal range of BMI, and about only a third of our country fits into that right now. The rest of the country is spread out over the rest of these BMIs, and the BMIs in the red box are the people who are currently allowed to have bariatric surgery based on criteria by the National Institutes of Health. The people in this middle are currently somewhat in a gray zone. They also get the diseases that come with obesity, but right now there is no approval for them to have surgery. So we currently have an epidemic of obesity, not only in our country, but in most developed countries. In our country, 3 in 5 Americans are either overweight or obese. Those rates have doubled in the last 20 years, and they're expected to continue to get much worse. So right now, this slide lists 300,000 premature deaths annually attributed to obesity and 400,000 annual deaths attributed to smoking, which is at one point considered the leading cause of death for U.S. adults. However, taking just 90,000 deaths from 2 common cancers and adding them to the early deaths from morbid obesity, in addition now knowing that at least 13 common cancers are associated with obesity, it is very evident and clear that today obesity is the leading cause of death for U.S. adults. And there doesn't seem to be an end to this problem. Again, because this is a genetic environmental disease, there is a vast majority of children who are going to become morbidly obese adults. This is despite any and multiple interventions that seem to be attempted during childhood. So the US population currently is around 325 million, so it's a very large number of people to deal with that have this disease. In a different way to look at it, as a pie chart, if we're looking at the population, normal BMIs comprise just about 1/3 of our country. The rest of the country is spread into the rest of those BMIs, which include a large portion of people that are now in the obese category. This red category includes a large portion that are already capable or meet criteria to have surgery, and 6% of the population is above 40. So the tragedy of this is that we're only operating on less than 1% of the people who meet criteria for surgery. Surgery is the most effective and most underutilized means of weight loss in our country today. Now, to give you sort of an update on the current prevalence of obesity, if right now our data shows that 35.7% of the country is in this category, the expectation is that half of the country will meet this criteria by 2030. That's a horrible statistic, but it's even much worse because there are expert opinions that feel that we're underestimating the BMI rate, and they're suggesting that we should decrease these BMIs to these very low numbers that seem potentially unattainable. This would mean that a vast majority of the country would meet criteria to have surgery, which is an impossibility at this time. The next set of slides are going to be very quick. They're going to show data from the CDC starting in 1985, going to 2014, showing a landscape of the country based on BMI. They started keeping track of people with body mass indexes above 30 to include everybody above that. And you can see that at that time, there were a vast majority of the states either don't have any data or they have a small amount of data. And as we go very quickly through the slides, you can see that the country keeps growing and growing and growing. Every state has data, and the data just continues to get worse and worse and worse. States are now having more than 1/3 of their population meeting this criteria, and we stop at data that is now currently 6 years old. And again, the data has just continued to get worse. So this leads us to a big question. Why should you do anything about obesity? Why treat it? And the answer, unfortunately, is death. As people get bigger and their body mass index gets bigger, their chance of dying increases exponentially. And the reason for that is because of the diseases that come with obesity. The top 3 killers are diabetes, hypertension, and sleep apnea. These are not all inclusive, but they're the most dangerous ones to have. Obviously, there are other ones such as cancer that are now very prevalent. Once again, we know that there are 13 common cancers associated with obesity. So, the impact of obesity on our health is multiple. Not only does obesity cause disability because of the diseases that come with it, but it is a burden on the medical system. The costs are much higher. It decreases people's quality of life, the way that they live, and we know that it brings on early death. Now, just with a BMI above 30, so this includes a large portion of people that cannot have surgery, there's a 55% increased chance of dying, a 70% chance of having coronary artery disease, a 75% chance of developing a stroke, which is now becoming more and more common in a younger population as opposed to the older population. And the worst one, a 400% chance of becoming a diabetic, the worst disease that you can get because it affects almost every cell in your body. As a comparison, a young man who has this disease has a 12 times chance greater of dying compared to a normal weight person, and a 33% chance of making it to age 65 compared to a normal weight person. And this is another slide that has the medical implications of obesity. And once again, you can see that diabetes, hypertension, and sleep apnea are up there, as are many other diseases that are currently common with obesity. NASH, or non-alcoholic steatohepatitis, is an up-and-coming disease that we're finding more and more common. I talked about 13 common cancers, and then there's a variety of other issues that afflict people with this disease. Psychological impacts of obesity are often ignored or downplayed, even by primary care physicians or all physicians. So people are depressed. They don't feel good about themselves. They may be socially isolated, not comfortable in public. They may lack intimacy, and they may have decreased libido. Physically, there are a huge number of things that people can't do. They can't go and have a place to sit in certain places, or in airplanes, or may have to buy 2 tickets. There's seatbelts that they may not be able to use. They may not be able to fit through certain places. They may not be able to get down on the ground and play with their kids, stay adequately clean, or buy clothes that off the rack. And the last part, the fact that obesity remains a last acceptable bastion of discrimination, could take another lecture. People may not be hired, or they may be fired, or they may be paid less, or they are seen often with negative connotations. Economic impacts of obesity are very difficult in this country. It is approximately 10% of the healthcare expenditure, and if you have this disease, you end up spending a third more compared to normal weight individuals. Unfortunately, this is old data. This is over 8 years old, and most people have realized that insurance companies continue to hike up the out-of-pocket expense that people have to pay before the insurance kicks in. So this is a very difficult problem. Now, the treatments for obesity that we're going to talk about, these are obviously all non-surgical, but diet and exercise, take in less energy, be able to burn more energy, have it be taught to you as part of a program, use some type of medication or drug that helps you take in less energy, and a variety of unusual treatments. So, same exact thing for severe obesity. And what do we know about diets, exercise, and behavioral change? We know a lot, because diets and exercise have been around for a long time, the time that food has not been an issue. So there are multiple and hundreds and thousands of studies about multiple different types of diets. And almost every diet that's here today has been out there before in the past, made famous or popular by a person that was able to lose a large amount of weight or do some incredible feat. So we know a lot about diets. One of the easiest ways that I like to explain about this is this show, The Biggest Loser. Most everybody knows what that show is, but if you don't, it's a show where they take a large number of contestants, all of whom are severely overweight or morbidly obese. They put them in a program where they are exercised, where they watch what they eat, and over the period of the show, they lose a large amount of weight, 100 plus pounds. At the end of the show, they look great, they feel great. Most of their illnesses are gone. But the question that I often place is, does anybody know what happens to these people a year after the show? And unfortunately, the answer is that a huge and vast majority of them bounce right back to the weight that they originated at, and oftentimes beyond. This is not an uncommon instance that most people who've been on diets experience. They yo-yo diet through life. They lose weight on a diet, they stop the diet, they gain their weight back, they go on another diet. And so the question is, why does this happen? And looking at the people in that show and actually studying them, which has been done in multiple labs, in multiple instances, in multiple times, show the same exact thing. When we as humans start to decrease our energy intake and start to lose any storage, it is an inborn genetic survival instinct that we start to experience hormonal changes. The hormones that tell you that you're hungry start to become upregulated. The basal metabolic rate of energy expenditure decreases. Hormones that tell you that you're hungry start to rise tremendously. And this is not under people's conscious control, where it's often thought that people who have this disease have some type of defect of moral character, of not being able to stick to a diet, and it's clearly not that. This is a survival mechanism that any animal has. And so we've verified that over and over and over again by looking at people like these in the show and putting them into closed system labs where all of this can be studied. So we know that as soon as a minimum of 5 to 10% of weight loss occurs, that these mechanisms start to kick in. And that's why people stop their diets. So we don't have an effective long-term treatment with diets. They are ineffective. And the same thing with drugs. There are multiple drugs out there that are getting more and more surgically targeted at specific pathways to block hunger. Unfortunately, it's not a single pathway that regulates our energy intake and expenditure. It's multiple pathways. And it's possible that when one pathway is blocked, another one takes over. And the big question is, are these drugs free? Are they cheap? Are they expensive? Are they covered by insurance? Do they have any side effects? What happens if you stop taking the drug? So we end up with the same idea, where when we look at medical treatment for this disease, we end up with a 95% long-term failure rate. It just doesn't work. So we can look at one of many studies that have been done in multiple countries. This one happens to have been done in our country, but there are studies that are done in countries where it's much easier to compare sets of people because everybody's on the same system, on the same computer. And the basic idea is you take a matched group. They're split based on desire. So one group wants to diet, one group wants to have surgery. And when these are matched and they're followed out for 2 years, you can see that all the patients that ended up having a diet or choosing a diet have regained their weight, whereas the patients who chose to have some type of surgical intervention maintained a medically significant weight loss. So the conclusion of the NIH and multiple other agencies is that surgery is the only effective means of treating severe obesity on a long-term basis. So at this point, we don't really have any options between medicine and surgery. And the basic mechanism of surgery is to help you take in less energy. Now, that is almost the exact definition of a diet. However, with surgery, it gives you an amount of control that you do not have with the diet. And how we get that control is important, and it's something that we're going to talk about when we talk about the surgeries. Now, this is probably the most important part of the presentation and the most important slide. And it's titled Realistic Expectations. So, first of all, any bariatric surgery does not cure this disease. This disease, again, is mediated by our genetics and our environment. We consider surgery a management tool for the disease. And the way that it works is if it's combined with a lifelong commitment to appropriate nutrition and the ability to burn energy. So I like to call it a tripod: a surgery leg, a nutrition leg, and an exercise leg. If people think that just having surgery is the cure, it is an incorrect concept. Now, when you use the word surgery, it brings up multiple ideas in different people. And certainly one being, I'm going to sleep, I'm going to have surgery. Is that dangerous or not? Well, we know that diet and exercise are not effective long-term means for treatment of this disease. It just doesn't work. We know that surgery is the only proven method for long-term weight loss control when everything else has failed. And the big question is, well, which is more dangerous? And it's actually been, again, shown in multiple studies that if you separate the people and you choose a subset that has had surgery and compare them to a subset that has not, it ends up that the patients that have had surgery die at a much lower percentage compared to the patients that choose not to do anything. In other words, staying obese and continuing to have these illnesses that come with obesity is much more dangerous and deadly than having surgery. So, why does surgery work so well? Well, with a large amount of weight loss, the diseases that come with obesity tend to get better, especially the most dangerous ones. So, if you're a type 2 diabetic, you have an exceedingly high chance of going into remission. Same thing for sleep apnea, same thing for hypertension, same thing for cholesterol. All leading causes of sudden death from heart disease and strokes. Now, there are a large amount of lifestyle benefits of surgery that people often tell us they feel. They can move better. They have more stamina, more energy. They may feel better about themselves in a society where obesity is seen as a negative. They may have better effectiveness. Their quality of life is much better. They may be less self-conscious. They can do things that they weren't able to do before, go places that they weren't able to go before, buy clothes that they couldn't fit into. Now, I always leave this last one as marital satisfaction somewhat clearly depends on where the marriage is and what happens after the surgery. Now, the goals of surgery are to improve health, improve quality of life, and increase lifespan. We do not consider this a cosmetic surgery. Oftentimes, insurance companies seem to fight on this. This is a side effect of the surgery. Now, the criteria of who can have surgery is a little bit old. It was made by the National Institutes of Health in 1991. So, if your body mass index is 40 or above, you can have surgery. It's an inclusion criteria. If your body mass index is between 35 and 39.9, then they want you to have a comorbidity that's associated with obesity, such as diabetes, hypertension, sleep apnea, cholesterol, all inclusive in the list. Because bariatric surgery from its very early inception has always been seen in somewhat of a negative connotation, again because of bias. Most bariatric surgery is done under a weight loss program where there is very stringent education, very stringent evaluation of patients. And part of this is what goes into the insurance process. So although we know that diets don't work, there's a insurance mandated thing that patients often have to go through a weight reduction program, sometimes varying from 3 to 6 months. We know that medication, diet, and exercise do not work. Now, there is a subset of people that it's probably more dangerous for them to have surgery than to stay morbidly obese. And that's people who are currently addicted to some type of substance, people who are psychotic and will not be able to carry out the instructions, or people who have uncontrolled depression. But probably the worst one is smoking. Again, trying to mix the two leading causes of death for U.S. adults is a terrible idea. But if you have surgery, any bariatric surgery, and you continue to smoke, it is almost a guaranteed problem. And so people who smoke have to have a very strong choice about what they're going to do in their lives. Absolutely cannot smoke, both before surgery and after surgery. And it's often a struggle that we have with patients that have to quit and choose what they want to do for their lives. Now, usually what I do next in the presentation is I talk about the surgical options that we have for obesity. But what I have found more effective in a group environment is I like to draw out sort of what normal anatomy is and how it works so that you can understand a little bit better how the surgeries end up working. So, now, this is going to be the esophagus and the stomach. This would be the diaphragm. It's a muscle that separates the abdominal cavity from the thoracic cavity. So above the diaphragm are the lungs, the heart, the esophagus, and below the diaphragm is a tiny bit of the esophagus, the stomach, spleen, liver, intestines, colon, etc. And of course, I like to draw out the brain because the brain is an important part of this process. So, to be a live animal, you need energy. And that desire for energy starts in the brain. So, you see food, you get hungry, you want food. Brain secretes hormones that tell you that you're hungry and you start to eat. So, when you eat food, food comes down the esophagus and it goes into the stomach. The stomach is basically a stretchy storage bag. And as it starts to stretch when you start to eat, it starts a very slow signal through a nerve that goes all the way to the brain that allows you to feel that the stomach has begun to stretch. Now, most people have a bite or two, they don't feel full. That's a good thing because as a cave person, you don't want to take a few bites and feel stuffed. You need to gather some energy. Now, as you continue to eat and the stomach stretches a little bit more, that signal is a little bit faster. You're starting to feel some food in your stomach. If you keep eating and keep eating and keep eating and you keep eating and the upper fibers of the stomach start to stretch, that signal is very quick to tell you that you better slow down or stop. You don't want to throw up your food if you're a caveman and there's no more food around. Not only does this work on stretching and feeling, but as you're eating, hormones are being released by the brain that are interacting with the intestine telling you that you're satisfied. So we use a combination of these factors when we do surgery. So, as it happens on our slide presentation, not by any choice, the Roux-en-Y gastric bypass was first, and so I choose to start out with that one. And so it's called the Roux-en-Y gastric bypass, what most people commonly refer to as a stomach stapling. Well, we use staplers for all our procedures, but the gastric bypass is a surgery that has been around since the 60s. It was a surgery that was initially done through an open incision. It is a surgery that probably have the most data on. At one point, gastric bypass was the gold standard and go-to surgery for weight loss surgery. So, with a gastric bypass, what we do surgically is we use a stapling device that cuts down the middle and leaves staple lines on both sides, and we're basically creating a small pouch out of the upper portion of the stomach. So we've now stapled and cut, so this little tiny pouch is no longer in communication with the remnant or the rest of the stomach. If you were to eat, the food would stop here and have nowhere to go. So first we do the pouch, and then we cut the intestine just beyond the duodenum. The end of the cut is then swung and brought up and connected to the pouch. And then we reconnect the end to the side of the intestine so that if you eat food, food comes down, hits the pouch, and of course stretches those fibers, which gives you a very strong and fast signal that you're full. Again, we have our brain here. So, because this pouch is very small, you can only take in a small amount of energy. And that is what we call restriction. It restricts the amount of energy or food that you can take in, so you're taking in a lot less energy. So, after you eat, you feel full, you take a small amount of food. Now, that food sits in the pouch, ideally for some time, and then it starts to fall through the bypass limb, so it's bypassing the stomach. Now, when that food basically gets to this new connection, the stomach is still there, it's still alive, it still makes acid and intrinsic factor and mucus. The pancreas, the liver, all secrete their material, their enzymes into the duodenum. All of that then ends up mixing with the food here, and then the food can now be broken down and absorbed throughout the rest of the intestine. So, the first part of why people lose weight with a gastric bypass is because they're taking in a lot less energy. The second part is that control. So because food has been rerouted, because it's not coming through the normal route, there's a change in the way that the brain and the intestines talk to each other. So there's a hormonal effect. This hormonal effect is the control. People are just not hungry. With the gastric bypass, there is a different way that foods taste at first. It's somewhat difficult to take a large amount of carbs in because carbs now fall into a live piece of intestine and create a very strong demand for an insulin rise, so people can not feel so good after taking in a large amount of carbs. It's called dumping syndrome. So there is a third way that the gastric bypass works, although it's often thought as a much minor way, but the length of intestine that is bypassed, that is used as a bypass, or the length of intestine, or added to the length of intestine that is not seeing any food, creates a slightly less amount of intestine that is now capable of absorbing processed food. So way down the road, the number 3 way that the bypass works is malabsorption. You are not absorbing all of the energy that you're taking in. So that is how the bypass works. Now, over the last decade or slightly longer, the sleeve gastrectomy has now become the most popular and most common procedure done probably worldwide. The sleeve gastrectomy is now an independent procedure that we have over a decade of data on. And once again, at this point, although it doesn't seem to be called the gold standard, it is probably the most common surgery being done in our country. So with the sleeve gastrectomy, we're using that same stapling device, and we're basically coming across the stomach, separating all of its attachments, and then coming with the stapler across, and then removing this large portion of stomach out of the body, leaving you now with a permanent, much smaller stomach that looks like a sleeve. So, how does the sleeve work? You eat a small amount of food, and that small stomach starts to stretch and tells you that you're full. So once again, restriction. You're eating a much smaller amount of energy. Number 2, in this section of the stomach, there was millions of cells that created a hormone that regulated hunger with the brain. Now, with the vast majority of those cells gone, there's much less of that hormone around. So you're just not very hungry. That's the control. It changes the way that the brains and the intestines talk to each other. Now, on both surgeries, and on any bariatric surgery, this effect is not lifelong. It would be unsustainable if you had no interest in food for the rest of your life. At around a year and a half, things start to change. So for a year and a half, you've lost weight to a much lower level without the normal response that would ordinarily be there to try to protect you. So you lose energy, you become at a much acceptable lower BMI, you get rid of these diseases, and then around the end of a year and a half, the body starts to find its ways back. Maybe the receptors in the brain are become more sensitive, maybe the little bit of stretch that occurs is releasing more hormone. And that's why it is exceedingly important to understand from the very get-go that this is not a cure. It is a management tool that has to continue to be used with appropriate nutrition and appropriate exercise. Thank you very much.